All right. Hello, everybody. Welcome to another episode of Finding Peaks. I almost forgot how to do this. It has been with all
you
the
haven't said exciting yet. I'll tell you.
Yeah.
that.
No, I didn't want to do the
Yeah.
exciting thing though. I'm trying to be new. I'm trying to be new for you, the viewer, so you can go, you know what? I'll watch that guy more often. Anyways, Brandon Burns, Chief Executive Officer for Peaks Recovery Centers, Chief Operating Officer Clint Nicholson,
Hello.
Chief Clinical Officer Jason Friesma.
Jay Freeze.
Welcome to the show.
Yeah.
Good to be back, fresh out of the holiday season,
Into the holiday season.
or into the holiday
Yeah.
season. We are in
Fresh
spirit.
in the thick
We're-
of the holiday season.
We are in spirit here.
Yeah.
at
Yeah.
Peaks. Anyways, for the viewers in the back, I've been listening to a lot of podcasts recently, and people start with a little joke,
Oh.
a little
Oh, wow.
festive, fun
Yeah.
conversation. I'm trying to recreate
Little
that
anecdote.
here.
Okay.
Yeah.
Yeah.
It works for them.
How's it
and,
going so
And
far?
this is ad-free.
Yeah.
This is ad-free. So
That's
you're,
true.
you have that.
We're
Anyways.
working on it. but-
Brought to you by Peaks.
Finding Peaks at peaksrecovery.com. Let us know if you care about our jokes.
Okay.
Here
we
we
haven't
are.
actually told a joke yet, though,
Yeah.
have we?
I know.
Okay.
Do you have a story you're going to tell though to start this
I
off?
had no joke. I was
Oh.
really hopeful you guys would bail me out on that.
I got nothing.
No.
Stay with us. We're talking about dual diagnosis today. I was recently at the NATAP conference, the National Association of Treatment Providers, and they do great work at the national level in support of individuals with mental health and substance use disorders. And they gather twice per year to bring treatment providers together, talk about ethics and a lot of other important things, outcomes and so forth in the industry. I like to go in there and just talk to the marketers in the crowd and just see what's going on. And so when I go up and I ask people about what they do, they'll say something like, well, we do dual diagnosis. And we've talked about this on our prior episodes. You can go to addiction treatment centers' websites and they will say something like, we do dual diagnosis treatment. So I'm sitting with this marketer of company X, and they say they do dual diagnosis. And I was like, awesome, so you do mental health primary. And they're like, no, it's got to have a little bit of the substance use disorder in there. And I was like, well, this is how I'm going to let you guys explain what dual diagnosis is. But in diving into it, ultimately my experience is that we don't really know what that means in this industry, and we really don't know what we're talking about. And this is consistent across treatment platforms. Namely that we're stating that we do it, but what I think we're really doing at the end of the day is stating something more like we do co-occurring disorders. So long as there is a substance use disorder, primary, tied to severe anxious disorder or major depressive disorder or schizophrenia or whatever it is, the substance use disorder has to be at the top for treatment centers to approach it. But that's not the true nature of dual diagnosis nor the approach to it, at least in my experience. And so let's just kick this off with what the heck is dual diagnosis? Because my interpretation of it is that you can have a diagnosis of a substance use disorder somewhere in the past and then a presenting major depressive disorder happening now. And it's dual diagnosis in the fact that they've been diagnosed, but they're also not happening at the same time as a co-occurring issue, which for me would mean that you could treat mental health primary within that moment under that dual diagnosis lens. Am I wrong? Am I the idiot at the conference? What's going on?
Never.
Thank you.
Yeah, you're welcome.
Yeah, I definitely don't think you're the idiot at the conference, Brandon. So you can just take a breath and feel okay with that. Okay, good. Thank you. I mean, I do think you are right, and I do think your assessment is correct that true dual diagnosis it can be primary mental health, or it could be primary substance use disorder as well. I do think, at least colloquially, when people mention dual diagnosis, it is assumed that one of those diagnoses is a substance use disorder, is my experience with that word. And actually, Clint and I are actually dually credentialed. We are licensed to be professional counselors, which is a mental health license, and then we're licensed addiction counselors. And probably not surprisingly, there's a huge overlap between those two licenses because a lot of the skills, and actually a lot of the skills overlap. And I think I talked about it at a previous episode of Finding Peaks, but I really think I would like personally, and I hope as a field we can move away even from calling ourselves dual diagnosis, because truthfully, the distinction feels arbitrary. It feels like that feels like old language to say, you know what, you don't have a true mental health issue if you just are an alcoholic. You just have kind of a characterological problem that you just need to quit drinking. That's where it just feels like antiquated conceptualization of people with mental health issues.
Right.
Absolutely. I think it comes from this idea that somehow substance use and mental health are different. Like there is this like grand distinction that if you have a substance use disorder, then you don't have a mental health issue, which by definition, substance use is a mental health diagnosis. So it's, again, I think arbitrary in a way. I think it's actually kind of confusing and can kind of conflate treatment to a certain degree. I think the fact is that if a dual diagnosis can be to mental health, I mean, can be, I don't know, depression and anxiety. I mean, that's technically a dual diagnosis, isn't it? A co-occurring disorder would be any two diagnoses that are occurring and presenting at the exact same time. It doesn't, so this idea that substance use, you have to have this special sort of substance use disorder in order to activate these other mental health disorders in order to treat them it goes back, like Jason said, to sort of old thinking, old definitions, and really this separation that, you know, we've talked about in length, that somehow mental health diagnoses and substance use disorders are different. And I think that, again, getting rid of that language is one good way to help try to eliminate this sort of barrier that actually doesn't really exist.
Yeah. And the project here for the viewers at the end of the day, of course, is just to familiarize yourself for how this industry works. At least when I'm in this host seat, that's what I'm really trying to get at in as many ways as I possibly can to inform you and help you when you call an addiction treatment center and you say, my son and daughter is dually diagnosed, can you help that? They're gonna say yes. But it's not clear to me that when I talk to treatment centers, particularly their marketers, that they're aware of like what that really means and what they're actually treating and whether or not there's an actual approach to that at the end of the day, other than catchphrases on websites to get phone calls to ring. And so what I'm advocating for here is certainly education and also too responsibility on the part of treatment centers that if you're going to put this stuff on your website, you better do it and take it seriously because there are families desperate out there for dual diagnosis care and approaches at the end of the day. So off my soapbox. That's my soapbox.
Welcome.
Well played.
Yeah,
Appreciate it. Thank you.
Nice.
And it's also too that I think we were talking about this a little bit earlier as well too, but it does seem to be like that we're just going to work on this major depressive disorder thing that's in the brain, and we're going to work on this SUD thing that's causing the alcoholism and things at the end of the day. But that's not really how treatment works, right? We're working on a variety of different features that are helping and supporting the individual live a better life, not necessarily curing those ailments within 45-day episodes, 90 or even 6 months to a year long, but gradually and slowly but surely making their lives better. And so within dual diagnosis approach to treatment, if we're treating somebody with major depressive disorder, for example, that's going to take a while to really nurture and treat as a diagnosis. So I was hopeful that maybe we could talk a little bit about what we're actually trying to alleviate in between in that time period to improve the life. Maybe it starts with getting out of bed and getting sunshine on your face and these sort of things, but it seems like in a very clinical sense that the project is greater than just these diagnosed things at the end of the day.
Yeah, I mean, I think you're exactly right. I think it's really important, when we consider treating somebody with depression, I think there are things that need to occur, medications usually, alternative or kind of new and progressive treatments like TMS, like we've talked about, or other ideas are important. And then there is an entire set of behaviors that I think that need to be encouraged and installed with people in education around how to manage depression and how to notice warning signs of relapse of depression. I really, it's interesting that we are talking about this because it has been on the forefront of our mind lately of how do we really begin to nurture the language we use at Peaks to say, to merge these mental health issues with substance use and depression, and how do we begin to say, like, there are signs you can tell when maybe you're not sleeping as you should, you're oversleeping, or you're not eating as you should, you're not getting the nutrients you need, or you've stopped exercising. These are warning signs that your depression is likely beginning to relapse. And it's fascinating how similar it is if you just overlay alcohol, heading all in the same direction. Because ultimately, if somebody comes into our program and they have depression and they have an eating disorder and they misuse alcohol and cannabis, frankly, those three things are usually just symptoms of the same kind of underlying and driving forces, and literally require very similar paths toward recovery for all of those. It isn't, we have to separate out eating disorder and separate out depression and separate out addiction. Like, we have to kind of teach skills and build resilience, and also probably in long-term recovery from all of those, like, deal with kind of the etiology of it. So,
yeah, I think that what we've in the past kind of looked at is treating symptoms, right? Like, you have this one specific symptom that is presenting itself with major depressive disorder, so we go after that one symptom. But that, again, kind of keeps us at the surface level and doesn't necessarily invite the clinician or the doctor to go further beyond that and kind of look at the systemic issues that are going on. And that doesn't necessarily mean that it's all about insight, though, and developing insight into where these, like, deep-seated feelings are coming from. It's also the systemic issues that come from just daily living. Like, how do I live my life? How do I actually change and adjust my day-to-day behavior to support my long-term recovery? And whether that's in, again, like Jason said, recovery it's a mental health thing too. It has, I think that we use that term and we automatically jump to this idea of substance use, but it's not. I mean, you can relapse from depression, you can relapse from schizophrenia, you can relapse from anxiety. I mean, all of these things happen because the behaviors that have been, or coping strategies that have been addressed or adopted essentially stop working, or you stop using them.
So this is all my beliefs, all of everything that I've certainly wanted to be for, and really energized by this discussion. In that regard, it seems actually very accessible to actually provide dual diagnosis treatment, right? I mean, take it seriously with licensures and the people actually equipped to be able to handle the complexity of such diagnoses at the end of the day. But so what are some of the, somebody comes into Peaks and they have major depressive disorder, and maybe they smoked pot 30 days ago, but it's not a primary concern, but it is a thing that, kind of gets entangled within that depressive disorder. At the same time at Peaks, we've got somebody coming in with, significant heroin or opioid use disorder on this side, and maybe several months ago they felt, depressed as an episode. So you're treating these individuals kind of at the same time, and then in our industry, I think in the way at that service level wants to kind of just push them off into their own centers and say they're two independent things. But what I hear and what I experience here certainly is that we're still looking at a brain disorder of some sort, and it feels reasonable and manageable to actually have them in the same group, stop talking about the darn diagnoses and what's contributing to the diagnoses themselves, but the relapse potential for them. And I mean, call me out if I'm wrong here, but sometimes it feels like the thing that's going on for the major depressive disorder, can't get up out of bed, motivated and so forth, is also happening with the opioid use disorder. And so the underlying behavioral issues often look the same, and makes it manageable to have them in the same group and operate from that direction.
I mean, what I thought of when you were saying that, Brandon, like, if somebody comes in and sits and does counseling with me, for instance, and they have a heroin addiction, you would be shocked at how little times the word heroin comes out of my mouth. You know what I mean? Like, we don't, maybe at intake, just to kind of get the background and all that, like, we'll talk about it, but, like, that isn't the thing, right? Like, there's all the other things. There's grief, there's resilience, there's shame, there's all these other things that are truly what we talk about, and building a support system, and really those all apply to whatever malady brings somebody. Like, if somebody needs inpatient treatment for mental health issue, they're in jeopardy too. Their life is in jeopardy just as much as somebody who uses fentanyl or something. Like, it may look different. It does look different. But like I said, it's not like 45 days of heroin treatment means all we talk about are war stories and needles and black tar and all that. That is not the case at all. There's all the other things that are underneath that, the human that's underneath all that and that. So.
And in both of those issues, whether you struggle with depressive episodes or you struggle with opiate addiction, there's a similar fallout in your life that has to be also addressed, right? Like all of those two diagnoses impact life in the same way. They destroy relationships. They interrupt stability. They completely they create barriers to self-growth and self-insight. All of those same things happen at the same time. They just happen for different reasons. But the reality is, like Jason said, that you're always talking about the sort of underlying motivations and the underlying things that are happening, rather than just going in. It's just similarly with depression. You don't just sit there and just talk about depression all the time. I mean, that would be like the absolute worst counseling session in the world. So tell me how depressed you are right now. It doesn't make any sense. So similarly, you're not going to just say, so tell me about all the heroin you did. Like that is not going to get anybody better. You know, it's everything around it that is actually what you're focusing on. And the reality is that life around any diagnosis is really similar in the sense that it's interrupted, it's disruptive, and it needs a different approach and intervention strategy to help it sort of be redirected and reinvigorized rather.
Yeah, love it. We're on fire right now. I feel like it.
Yeah.
I hope it's burning on the other side of the screen. Yeah,
Absolutely.
This is good
Just come
stuff.
up with words. Yeah.
What I think I want to, I'm in a lane of curiosity here now. So so we have these underlying things. So I was thinking about it on my drive back from NATAP, thinking about like cocaine use disorder, right? That somebody has these underlying conditions for which they're operating under, and somebody with major depressive disorder has these underlying, things, behavioral or otherwise, that are happening. And it just seems like at the level of cocaine use, you hear there's all types of war stories about people who have very similar traumatic backgrounds, happening at different times for different reasons and so forth. But two traumatized people can go to the party and the club at night, both engage in cocaine use significantly that night, and one will put it down and never come back, and the other one gets fired up about it and shoots off in the difficult direction of having a cocaine use disorder. But it seems like one person is just more vulnerable or susceptible to that in a way that the other person isn't. And so the drug use or the addiction actually takes place out of that vulnerability, rather than two individuals who still need to nurture these underlying behaviors. This one just didn't get addicted, and so maybe it goes unseen, but this individual is still struggling deeply as much as this individual over here. And if we're vulnerable to drugs, are we also vulnerable to those major depressive disorder states and anxious states as well too, differently than other people who experience similar symptomology?
Well, I think in kind of this theme of dual diagnosis, like I did a lot of work with guys in the Army coming back from Iraq and Afghanistan before Fort Carson here locally got the Wounded Warrior Project and all the other things going. So I was just a community therapist, and all of a sudden I was inundated with all these guys coming in from the field. And, I like to say, like with PTSD, 6 guys in an armored personnel carrier gets blown up, 2 people die, 2 people get PTSD, 2 people shake it off and keep going. And it's kind of unpredictable. To your point, and there probably are factors, but like we can't predict. At least last I knew, we can't really predict who's going to get PTSD out of it and who isn't. But to your point, like people are differently susceptible to literally the same stimulus event that occurs. That's what I observed happen. And I think it absolutely applies to the same thing. Like some people, to your point, try a hard drug. We're like, okay, that could take or leave that. And other people are like, that is a glove going onto my hand. That is a natural fit for me. And it's the parallels are just remarkable, I think. When you mentioned a minute ago, like, why would this be so hard to treat, these two things? But because our entire industry bases it upon it. We have 2 different licenses for mainly overlapping skill sets, to be honest with you.
Yeah.
And I think it's just an antiquated, if you ask me, an antiquated thing. And now, I don't know. Go ahead.
Well, I agree. I think that you have two people that come in with PTSD, and then especially when they're coming into treatment, what you're seeing are just maladaptive responses to that, right? So one person's maladaptive response might be to use heroin. Another person's maladaptive response might be to restrict food, or to maybe they start to develop and go into these depressive states where they're completely detached from the world and their relationships start falling apart. The reality is that that's really what we're treating. We're just treating maladaptive behavioral responses to triggers in the world, right? So I think that again, this idea of having we live in these sort of separate treatment worlds of mental health or addiction, it's just not true. I mean, in the end, it's just I've responded to something in a maladaptive way and it's destroying my life. Regardless of what that presentation or behavior is, I'm falling apart. And so I need help. And that's what we do, right?
Yeah.
To be clear too, like there are nuances of treatment that do need to be specific, right?
Sure.
Like everybody just can't walk in and you're like, oh, you have anxiety, here's Prozac, you have depression, here's Prozac, you have a heroin addiction, here's Prozac. Like there has to be nuanced treatment for all these things, and certainly in individual therapy, some form of relapse prevention or there will be individualized aspects of it, but the overall core, I think, is remarkably similar on the treatment of all these things with some little pieces of nuance.
Absolutely. Certainly more similar than we ever really talk about or give it credit. Yeah. But again, to Jason's point, like it is more complex than that, or else this would be a cakewalk, right?
Yeah,
but there is definitely nuance and specificity and specialization. But ultimately, as I think clinicians, you recognize that really you're just treating people in pain. That's really what it comes down to.
Yeah, it's a fascinating hyphenated, is it hyphenated dual diagnosis, or is it just two words?
I think co-occurring is hyphenated.
Co-occurring.
I think dual diagnosis
or you can smush it together. You can do it either way.
Yeah.
Co-occurring.
Yeah.
Co-occurring.
Later we'll figure out the spelling of this, but it's language that's used all across the board. I think as a society we're very familiar with it as a language and kind of what it means, but it's interesting that it is all the little things, sort of below the surface of the language that's taking place at the end of the day, and how still within the framework of addiction treatment centers, and to be absolutely charitable, this is not all treatment centers, of course, I'm just talking about the ones I picked on at this conference, and their marketers, bless their hearts, they do PHPs. At the end of the day, how do I want to take this out on? Is that though we're saying we do this, how quickly it's treated as this binary thing, that the SUD has to be this presenting factor, or else substance use disorder treatment, or as a substance use disorder treatment, or as an addiction treatment center, we can't treat anything else that's going on if we can't minimally tie it to that SUD language. And so my point here to the family systems that are watching this, if you haven't tuckered out yet, in that regard, is to be mindful of that when you're calling places and ask those thoughtful questions about that at the end of the day, because if your loved one's presenting with mental health as a primary major depressive disorder and they smoked pot, or whatever the case was 30 days prior, that on those excited admissions line, they're gonna say, yes, we treat dual diagnosis, yes, we can handle that. Oh, and I heard that substance use disorder thing in the background. Yeah, we can definitely do that, but it's not about the pot in that condition, right? We're treating something unique, and you want to find a center that can commit to that as a project, or all of its underlying features, and treat those individuals equally in a room with opioid use disorders and everything else that's going on. So that's kind of my general takeaway here that I want to leave the crew with. Any final words from you guys about this? Though I thought you guys were well spoken.
Thank you.
Really good.
Appreciate it.
Full
I think I made
stop.
up a word.
That's usually what I say at the end of things. Full stop.
Full stop.
Yeah.
Gold stars.
Gold stars.
Oh, gold stars.
Yeah.
Cool.
Yeah. There's green and red too, but gold's the best.
Yeah. Oh, okay.
That's my joke. You guys got it. The viewers got it too. That's it for us here at Finding Peaks regarding dual diagnosis. Hopefully we were able to dive a little bit deeper into that, elaborate it on a little bit, pull out some of the frustrations from that language, and give you all greater information to guide treatment for your loved ones, your family members, and so forth. Finding Peaks at peaksrecovery.com. Questions, thoughts, ideas, Hated your jokes, Brandon? Send it all to that space. Find us on the Facebooks, the Twitters, the Instagrams. What else is out
YouTube.
there? YouTubes,
Yeah, iTunes or
iTunes,
Apple's
podcast.
yeah.
I'll get it
That's
right
how I
one
listen
day.
to it.
Appreciate you all for joining us. Until next time, we are out.